Contrast-induced acute kidney injury is being increasingly referred to as contrast-associated acute kidney injury. That is because post-contrast AKI may have causes other than contrast exposure. AKI is classically defined by the KDIGO, that is Kidney Disease Improving Global Outcomes 2012 criteria, as an absolute increase in serum creatinine of 0.3 mg per deciliter or more within 48 hours, a relative increase of 1.5 times baseline or more within 7 days, or a urine output of less than 0.5 ml per kilogram per hour for at least 6 hours. Diagnosis of contrast-induced acute kidney injury following intravascular contrast exposure needs exclusion of alternative etiology. It remains one of the most common causes of iatrogenic renal failure, particularly following percutaneous coronary interventions, and is independently associated with prolonged hospital stays, increased short-term mortality, and a higher risk of subsequent myocardial infarction and target lesion revascularization. The exact mechanism is multifactorial, but it fundamentally hinges on an imbalance between renal oxygen supply and demand, compounded by direct cellular toxicity. Medullary ischemia. The renal medulla operates on the brink of hypoxia even under normal conditions. Contrast media increases blood viscosity and alters renal hemodynamics, leading to intense prolonged vasoconstriction of the vasa recta and subsequent medullary hypoxia. Direct tubular toxicity. Contrast agents exert a direct cytotoxic effect on the renal proximal tubular cells. The hyperosmolality of the contrast draws fluid into the tubules, increasing intratubular pressure and decreasing the glomerular filtration gradient. Oxidative stress. The ischemic environment generates reactive oxygen species which further exacerbate endothelial dysfunction and tubular damage. Risk stratification. The most critical step before angiography is identifying vulnerable patients. Pre-existing chronic kidney disease is the single most powerful predictor. Fixed risk factors. Pre-existing CKD. Estimated GFR less than 60 ml per minute per 1.73 square meter. Diabetes mellitus. Advanced stage more than 75 years. And congestive heart failure, NYHA class 3 or 4. Modifiable peri-procedural risk factors. High contrast volume, more than 100 ml. Hypotension or hemodynamic instability. Nephrotoxic drugs, NSAIDs, etc. Anemia. Routinely calculating the estimated glomerular filtration rate is mandatory. The Mehran score is widely validated for PCI, assigning points for parameters like hypotension, IABP use, CHF, age, anemia, diabetes, contrast volume, and baseline eGFR to predict the risk of contrast-induced acute kidney injury and the potential need for dialysis. Please note that metformin does not cause contrast-induced AKI, but it is typically held 24 hours before and 48 hours after procedures in patients with eGFR less than 60. This is done to prevent lactic acidosis in the event that CI-AKI does occur and the drug accumulates. Cath lab prevention strategies. Once a high-risk patient is identified, procedural strategy shifts heavily towards contrast conservation and optimal hemodynamics. Tailored hydration. Intravenous hydration with isotonic saline, 0.9% sodium chloride, remains the cornerstone of prevention. While standard fixed rate protocols are common, recent evidence favors tailored hydration, adjusting the fluid infusion rate based on objective measurements of volume status, such as left ventricular end-diastolic pressure or urine flow rate, outperforms standard regimens in preventing contrast-induced AKI without significantly increasing the risk of pulmonary edema. Contrast sparing and selection. Volume limits. The total contrast volume should be strictly minimized. A universally accepted threshold is maintaining a contrast volume to eGFR ratio of less than 3.7. Contrast type. Low osmolar or iso-osmolar contrast media are recommended over high osmolar agents. Diversion systems. Devices like the divert system can self-adjust to injection pressure, diverting excess contrast into a reservoir rather than the systemic circulation, often achieving approximately 40% reduction in contrast volume without compromising image quality. The divert contrast reduction system developed by Osprey Medical is a dedicated contrast sparing technology utilized in the cath lab to minimize the risk of contrast-induced acute kidney injury, particularly in vulnerable patients undergoing diagnostic angiography or percutaneous intervention. Its primary function is to reduce the total volume of contrast delivered to the patient without compromising the fluoroscopic image quality required for the procedure. Mechanism of action. During standard manual injection, physicians typically deliver a volume and pressure of contrast that exceeds what is actually necessary to opacify the target vessel. This excess contrast flows back into the aorta and systemic circulation, increasing the renal burden without adding diagnostic value. The divert system addresses this fluid dynamic inefficiency. Pressure modulation. The device is installed in line between the standard manifold and the diagnostic or guide catheter. Active diversion. As the physician performs a manual injection, the system's proprietary valve sends the injection pressure. It dynamically self-adjusts to fluid resistance and diverts the excess non-diagnostic contrast into a secondary reservoir bag before it ever enters the catheter. Maintained opacification. Only the contrast volume necessary to achieve optimal coronary opacification is allowed to proceed into the patient. Clinical utility in the cath lab. Volume reduction. Clinical studies and registry data typically show that the divert system reduces total contrast volume by 30 to 40% per procedure compared to standard manual injection. Real-time monitoring. The system includes a wireless digital display that tracks the cumulative contrast dose in real time. The operator can input the patient's baseline eGFR to establish a maximum contrast threshold, example contrast volume by eGFR ratio of less than 3.7. The display alerts the team as the patient approaches this limit. Target population. It is most frequently deployed during complex multivessel PCI or chronic total occlusion interventions where prolonged imaging is required, specifically for patients with pre-existing CKD, diabetes or advanced age. System variations. There are a few iterations of the technology such as the Divert Plus and Divert Plus EZ, which streamline the setup process for the cath lab staff, integrating more seamlessly with standard manifolds and automatic contrast injectors. By actively mitigating the volume of contrast administered, it serves as a critical mechanical adjunct to the pharmacological and hydration protocols used for high-risk renal patients. Coming back to other cath lab prevention strategies, procedural techniques. Radial access. As demonstrated in the AKI matrix trial, radial access is associated with significantly less AKI compared to femoral access. This is largely attributed to reduced bleeding and thereby less hemodynamic instability and a lower risk of catheter-induced atheroembolism to the renal microvasculature from descending aorta manipulation. Biplane versus monoplane. While biplane angiography can theoretically reduce contrast use, it drastically increases radiation dose. Monoplane fluoroscopy with careful test injections and software road mapping remains the default approach. And finally, a word on pharmacological adjuncts. Pre-treatment with high-dose statins like atorvastatin 80 mg or rosuvastatin 40 mg in statin-naive patients is recommended. Statins largely confer protection through their pleiotropic anti-inflammatory properties and improvement of endothelial function independent of lipid lowering. Trials involving N-acetylcysteine and sodium bicarbonate, like the PRESERVE trial, have largely failed to show consistent benefit over standard saline hydration.